Thank you, everybody, for joining us. And it's my pleasure to introduce Dr. John Kyle Bowman, who's thankfully donated his time to speak to us this evening. I, as you know, recently spent some time at the Mayo Clinic with their Ecmo program, with Dr. Bowman as my supervisor. And he has a talk prepared just to talk about their own sort of local experience with development and expansion of their own Ecmo program. So Dr. Bowman completed medical school at the University of Minnesota and subsequently completed his anesthesiology residency and critical care fellowship at the Mayo Clinic in Rochester, plus additional extramural ECMO training in Europe. During his training, he was the chief resident anesthesiology as well as chief critical care fellow. And he's the current Mayo Clinic Rochester cardiovascular surgery, mechanical circulatory support, and thoracic transplantation ICU program director. And prior to this, just before my time with the team, he was the medical director of the Mayo Clinic Rochester ECMO program for 5 years. And during that time, he oversaw significant program growth and led the program through the height of the COVID-19 pandemic and all of the innovation that came along with that experience. And he considers himself to be a servant leader rather than aspiring administrator. And certainly through my time at the Mayo Clinic, one of the things that I appreciated based on my talks with Dr. Bowman is that you assume a pillar with a global reputation as a cardiovascular center like Mayo Clinic Rochester is, perfect at all times, but it's clear that their sort of innovation and agility in evolving and developing their own program is sort of part of what makes them great. So without further ado, I'll hand things over to Dr. Bohman to begin his presentation.
Yeah, much appreciated. And thanks again for inviting me to speak with this group. It was a pleasure to get to meet and work with Dr. Landau during his time here. So it's a pleasure to meet some of his colleagues as well today. As he had mentioned, I am hoping to go over some of the lessons that I and our team have learned over the process of growing our ECMO program. So just to give you some background about the program in general, our program started in the early 2000s, and it was primarily born out of the peds CV surgical practice, much like many of the early ECMO programs. Those were the early indications with the best data at the time. And following that, much of the growth that we saw was related to adult post-cardiotomy indications. I think one thing to note at the beginning is that there really is no textbook for how to grow and run an ECMO program. We have encountered things in our program like a significant amount of growth in volume and diversity of our ECMO program. We've added things like an ECPR program, which required setting up a system for 24/7 emergent cannulations. We've encountered a perfusionist shortage and had to work through that. Of course, we ran into a pandemic, and that was quite the experience. And then the most recent challenge we're experiencing is a quickly growing transplant practice. So a little more background, just so you get an idea of what our program is, and to sort of prove to you that I'm not just some bum off the street. Here is a graph of the volumes we have for ECMO runs per year, and roughly where these dark blue and green lines kick in is that's shortly after I took over my tenure. But as you can see, there's been significant and continuing growth of the program in general. And one interesting thing about the growth is it has resulted in more diversity in indications. So as you can see in the beginning, we were primarily a post-cardiotomy program. And little by little, we've introduced more use of ECPR, respiratory ECMO, various cardiogenic shock indications. And then in 2020, we haven't seen it yet, but I think following transplant growth in our program, we'll see that area pick up as well. As far as our outcomes go, we have benchmarked ourselves against the ELSO database, and this is a nice thing. And if you're an ELSO center, they offer you this free of charge. Well, sort of. I mean, you have to pay to be involved in ELSO, and you have to give them a lot of data that they can use. But it also allows us to benchmark ourselves, and I'm proud to say that our program is significantly better than average for mortality outcomes, despite what I think are a very challenging group of patients and challenging referrals from all over. So with that out of the way, what I'm hoping to do is walk through what some of the resources needed are for successful ECMO program growth, talk a bit about ECMO indications and how one could or should prioritize those indications, and then a bit at the end about what the real value of ECMO and an ECMO program is. So first, the main things you need to grow are, of course, adequate staff, and then space. This at first may be a minimal space requirement, but as the program grows, this can expand quickly. And then ample hospital resources. So first, about staff. One of the big questions that always comes up for programs is, what about bedside staffing models? Do we use ECMO specialists or perfusionists, or what should we use? And what do other successful centers use? So here we use ECMO specialists at the bedside, and they either have an RN or RT background. And we recruit them in and give them additional training. Our typical staffing ratios are anywhere from 1-to-1 in a complex, fresh pediatric patient to at the most 1-to-4, which we did occasionally for stable VV patients during the pandemic, for example. But the administration occasionally asks us to justify why we need so many ECMO specialists. Why can't we do more cases with less ECMO specialists? And so to help justify that to everyone, we do benchmarking every once in a while. And this is our recent benchmarking against other similarly sized programs in the US that we performed just within the last year here. And what we found is that there still is a broad range of coverage models. Certainly some centers out there that still are perfusion based. Some, the majority are, just like ours, a mix of RNs and RTs that become ECMO specialists. And then as far as staffing ratios go, there really is a broad range of what people do. I think part of this depends on what your patient types are like and your other staffing on the floor is like. I mean, what is your nursing staffing like at the same time? What is your APP coverage like? How many intensivists do you have around? So it sort of depends on how they fill into the bigger picture. When thinking about advantages and disadvantages of a higher staffing ratio, things that you weigh in are, on the one hand, you could reduce costs, potentially assuming outcomes aren't hurt or complications don't increase by you using less bedside staff. You, in theory, could cover a greater maximum number of ECMO patients. And in theory, also, you could potentially pull less staff like nurses and RTs from other areas of your practice if you staff lighter. On the other hand, what we use to help justify providing more bedside staff is that we think there's probably a reduced risk of adverse events. We certainly think that we are able to mobilize our patients more and do much more PT with ample bedside staffing. And then it also helps us relax a bit more on the nursing and mid-level and intensivist level as well, knowing that we have closer eyes on the patient and we don't have to be quite as paranoid about the patient at all times. So another thing that's important to be prepared to justify during periods of growth are bed utilization, whether this is done preemptively during meetings just to prepare the hospital for what you're hoping to achieve and how many beds you are planning on taking, or just being prepared to justify it whenever you're questioned about it. Admittedly, it's a low volume of patients, but they are in the hospital for quite a long time. So their total bed utilization really adds up. I think opportunities to help you in these conversations would be that ECMO in general has a positive impact on the finances. There are some rare exceptions, but I think by and large, all the ECMO programs tend to come out positively. And Also, another thing that may help is in times of bed crisis or shortages, you can work out ways to adjust your selection criteria for ECMO patients so that you can responsibly use hospital resources, understanding that in times of crisis, such as the pandemic or other times, there are many other services and many other patients that would be vying for the same resources and beds at the same time. Just a short list of hospital resources that need to be available and are called upon quite frequently for ECMO patients. Obviously, lab needs to be prepared for any growth, for radiology, vascular surgeons like the good Dr. Landau, and other consulting services, nephrologists, palliative care, even the blood bank, depending on the indications that you're planning on growing. Say VV shouldn't have too much of an impact on the blood bank, but if you're growing a post-cardiotomy or transplant practice, you tend to endure a lot more blood loss in those situations. PT and OT, currently that's been an area of shortage across our hospital in general. So it's something that is somewhat limiting growth in areas of our practice. And unfortunately, I think may impact outcomes as well, because they are obviously acutely ill for quite a prolonged time. And without PT, they'll become more debilitated. And then having a good relationship with your echo colleagues, especially if you need to call them in the middle of the night. It's best if they have a good understanding about why these indications for echoes in the middle of the night might be urgent. Another very big area that needs to be considered when embarking on growth of an ECMO program is how to do education and training of all the staff involved. It can be extremely time intensive, but absolutely critical for the success of a program. A lot of the learning is didactic, but everything you need to learn for those critical, highly acute, and potentially mortal complications requires wet lab drills, in situ simulations, bedside training, and just by virtue of needing to get multiple people together to do simulations at the same time while also juggling their work schedule, that is really the big challenge for making these things happen. But it is absolutely worth making that happen. Also agrees, and in their guidelines for ECMO centers and guidelines for training, they specifically lay out things that need to be done to adequately train bedside ECMO providers, including ECMO specialists and intensivists. There are nice guidelines published by ELSO that you can find on their website, and to help alleviate some of the burden that you could find in delivering education to your program, ELSO has recently developed and has available for purchase a training program. All of this is sort of module based and didactic based, so it doesn't bill you out for all of the simulations that you need, but it can certainly help a lot of centers, because education certainly takes up a lot of time and energy to create content for. The picture on the right here is just a picture of one of our in situ simulations where we're using one of our 3D models to do an ECPR cannulation. And if ECPR is something that you head down the path of, I think these in situ simulations are invaluable, not only for your ECMO team to just get the steps down and get more efficient, but also to build that relationship with the referring area, whether it would be the ED or the CICU, whoever's calling you for an ECPR consult needs to know that when you rush in the room, you need this area of the room cleared. They need to know that they most likely are going to be the ones continuing to do ACLS while you focus on cannulating. Another big area that takes a lot of work, but certainly pays dividends, is the development of local guidelines for your practice. This is something that I built up early when I took over the program, and certainly has paid off over time. Essentially what it does is helps you standardize the practice and spread a lot of knowledge broadly across the whole program. Hopefully helps you avoid common errors. And then for an example of patient selection guidelines, I think that helps improve your transparency of your practice more broadly, so that when, say, the MICU consults you for a patient and you say, no, they don't meet our selection criteria, it shouldn't be a surprise to them, or it's not you meeting in the back smoky room making some sort of devious plan about who gets ECMO and who doesn't. It's nice and transparent, and if people want to weigh in on that, they can. In my mind, what I think the essential guidelines are would be patient selection, definitely, sort of the maintenance of devices, storage setup thing. Anticoagulation guidelines are extremely helpful. We have a heparin-based guideline here and a direct thrombin inhibitor guideline here, one for adults and one for peds. Cannulation guidelines, mechanical ventilation while you're on ECMO, percutaneous site care guidelines, and then cannula securement guidelines. I would call all those essential. And then other very common guidelines are here listed to the right that are just common questions that pop up. The repeat anticoagulation is in reference to some of the monitoring antiplatelet drugs that sometimes come up as questions. So I think I've got a couple pauses throughout the presentation just to see if there are any burning questions on what we've covered so far.
Dr. Bowman, maybe I will start off with a broader question that I think is an overarching theme of a lot of the stuff that we've talked about, which is this was excellent so far. When you think about something that's a fairly radical evolution, like changing to an ECMO specialist model from a complete perfusion dependence, or let's say introducing ECPR into your program where it wasn't present before, that's a fairly radical cultural change. And I would have to imagine that cultural change at the Mayo Clinic, the center being what it is not the easiest thing to achieve. So could you comment a little bit maybe on how to navigate that part of evolving something that radically?
Yeah, you're really right on. It's a change management process. It requires all the usual tips and tricks of other change management issues. You need to get people aware of why a change needs to happen, get people to buy in and have a desire to make it happen, and then move on to knowledge about how it can and should happen. And then I'll touch on this later in the talk too, but because it takes a lot of work and effort to plan for and to set up for these things and to get all of the stakeholders to buy in, I think it's wise to embark on one big change at a time. And I'll get into that further later in the talk, but taking chunks at a time rather than trying to tackle everything and, launching a lung rescue program and ECPR at the same time and changing a staffing model. Rather than trying to do all that simultaneously, I would, at least in my mind, I would take that in chunks.
That's great. Thanks very much. Anyone else have any questions? Feel free to, Murat, go ahead.
Hi, I'm sorry, I don't have my camera on, but I just wanted to ask a question regarding who is part of your ECMO team, and specifically, do you have intensivists or sort of people interested in acute respiratory failure as part of that team to try to help develop some of these, for example, ventilation guidelines and facilitate care of these patients in the ICU?
Yeah, thanks for that question. Yeah, I certainly left that part out. So the core of our attending ECMO team are anesthesia, critical care, intensivists, most of which are also dual trained in critical care and cardiac. And that's the core of our group. For cannulation related issues, we still always have our cardiac surgeons as the default for cannulations. However, there is a growing group of us that has become more and more proficient at cannulation. So those of us who have gone through training and locally and then have had enough sufficient cannulation experience, we can, for example, for a VV cannulation, call up the cardiac surgeon who's on call and say, hey, we have a great candidate. I was going to do VV, but just want you to let you know what's going on and hoping you could be back up. And that's the end of the conversation for those of us who have built up a good relationship with the surgeons and have done a number of these. But for those who are newer on staff, maybe covering the ECMO service and haven't done enough cannulations yet, their call is right to the CV surgeons, and they know that they are the default for all of our cannulations. For things like developing ventilator guidelines, that we worked with our MICU on, and obviously ARDS management and ventilator management is one of their passions in clinical life and research life. So we lean heavily upon our colleagues for that. And then things like limb ischemia monitoring, we leaned on our vascular surgery colleagues for making sure we had the best monitoring possible. So using NIRS, our default is now to have a distal perfusion cannula. And so it's borrowing a lot of knowledge from colleagues around us and just using what we've got around us.
Thanks.
Mm-hmm. So we'll have time for more questions later on, but the next thing I wanted to touch on is just wanted to make sure to emphasize adequately the importance of patient selection in an ECMO program. It's really essential to understand that ECMO patient selection nowadays is the #1 determinant of outcomes, and also huge determinant of bed utilization, like the stay and resource needs. I think back when ECMO first started, a lot of the outcomes were dependent on complications. You know, a third of all these babies they put on would, in the bad early days, they'd have a head bleed, and that would be the outcome there. But we've come so far with ECMO circuitry technology and anticoagulation management that the risk of complications from ECMO itself is substantially lower than it used to be. So now the primary determinant of outcomes is really boils down to patient selection. As my mentor often says, patient selection in ECMO is king. And to be fully inclusive, we could say it could be queen. So touching on prioritizing ECMO indications, I think things to consider are, what's the goal of growth at a particular program? Is it just growth in general, or is there a specific need at your center for which you're growing? And what is the ultimate scope of the ECMO program at your center? For instance, are you going to be focusing primarily on ECPR or ARDS, post-cardiotomy? And I think just in general, advice that I give to programs is that they should focus on some areas that are more likely to have early success so that the program can build some momentum and get more broad buy-in and support, rather than jumping into the really high risk and those indications with, say, really long lengths of stay and not so great mortality outcomes, because that can really bias people against ECMO in a hurry. In regards to Dr. Landau's question earlier, I think this comment here touches on that. This sort of shotgun approach of trying to take on multiple things at the same time may be too much to take on all at once, and it could ultimately hurt outcomes. And then again, a reminder that a need to be prepared to justify the resources that we use. So one example of something that we recently embarked on in regards to resource allocation and using all the resources that ECMO require responsibly was our Minnesota statewide ECMO Consortium. This is something that we quickly launched at the beginning of the pandemic because we were fully anticipating that the wave of COVID would totally occupy our ECMO capacity across the state. And we wanted to be prepared for that and prioritize its use as best as we could. So what we did, and this has since been published in Chest for more details if anyone's curious, but we sought to emphasize those indications that had higher survival percentages and shorter durations of ECMO. So if you maximize those two things, then in theory, you could help more patients achieve better outcomes. We also factored in other just general mortality indicators in ECMO. Age is a huge determinant of outcomes in ECMO, and then SOFA scores as well. So these are examples of the indications that fall into this allocation matrix here. So box A, B, C, D, E, and F. So the best indications would be, say, a neonate with meconium aspiration. Great outcomes, usually a short run. That's just the perfect ECMO patient that you should never miss. So they were prioritized highest. And then, unfortunately, those who fell down lower on the list would be, for example, someone who hasn't been worked up for transplant, but they have terrible lung failure and you don't think they're going to recover. So you put them on ECMO as a bridge to decision about lung transplantation that historically has a low anticipated survival and a long duration of support. So that would be de-emphasized in this scheme. Other things to be aware of and just prepared sort of mentally to handle in an ECMO program are the following ethical challenges. Many of these have popped up because our ability to support patients is so robust now with ECMO. You can have full cardiopulmonary support, and that oftentimes is a much stronger than our ability to actually treat the underlying disease. So you end up in situations where in the middle here, this is sort of the nightmare scenario of every ECMOologist I know of. It's this bridge to nowhere situation. If you do ECMO for long enough, you will unfortunately end up in a situation like this. The most recent one that springs to mind for me is this 18-year-old local high school kid, was a star athlete and then got myocarditis. So was put on ECMO, was not recovering over months, was being worked up for transplant, but could not be listed for transplantation because of alloimmunization. And so you're stuck then with, in a way, completely neuro intact one young kid with no exit strategy. And then the discussion turns to, sorry, when do you want to, what day do you want to die? We can't continue ECMO forever. So this is truly a nightmare situation for anyone involved, and not just, and part of the reason I bring this up is because you have to be prepared to not only help you and your colleagues through this, but the entire staff around that situation. These patients could be on ECMO for weeks or months, and all the bedside nurses and ECMO specialists build up a really good relationship with the patient and their families. And then it all kind of tumbles to an end, and it really is a painful death in those situations. Other things to watch out for are patient selection pressures and any bias. So as much as we can, we try to have at least 2 consultants or 2 attendings involved in the decision-making for any new ECMO initiation, just to relieve any one person of having all of that burden on them. It's much easier to say yes to putting a patient on than it is to say no. Other things that are helpful for this are in situations of crisis or near capacity situations. We launched an ECMO review board. It was a group of stakeholders from multidisciplines, and no one involved in the voting was directly involved in patient care, so they could be as objective and unbiased as possible. And then finally, things like selection criteria for ECPR are critical for this because of the time constraints and decision making. You need to arrive and within a couple of minutes say, yes, we're going on, or no, we're not. There's no time to call up a few colleagues and say, hey, what do you think? Another just general comments about sequence of growth. Yeah, obviously this isn't a dictum by any means, but just a general suggestion about potentially starting a program off with less urgent indications, things that typically have less complication risk and typically use less resources. So that would be something like starting out with a program with ARDS. There's a patient failing. When you need to cannulate, it's not an emergent situation usually. It's just urgent. You've got a few hours to organize people and get things set up. And then I think out of all the ECMO indications, the hardest to achieve is ECPR. It requires a really finely tuned system and lots of, at times, redundant resources in place that can be freed up at a moment's notice. And another pause here for any other questions that may have popped up. If not,
we'll save them for the end.
Sure, works for me. So the other thing I wanted to touch on was helping all of us make a good argument for why ECMO is important. There certainly are ECMO believers out there and people who just simply don't believe in ECMO. Even despite mounting evidence, including trials over time here, it at times can take some convincing of colleagues and administrators about why we should even do this. Just at a patient level, which I shouldn't say just at a patient level, I think most importantly at a patient level, there certainly is clinical benefit. And there's clear evidence now, I think, in ECPR, and there's pretty strong evidence as well in ARDS, even though the p-value wasn't quite where we wanted it to be. I think all things considered, those trials, the EOLIA trial in particular, in my mind, strongly supports the use of ECMO and ARDS. Another value that is sort of indirect is that it can help expand some high risk and interventional areas of the practice. Just knowing that there is a safety net there, whether peri-procedural or just as a backup means, has allowed colleagues around me to be able to take on some more challenging cases. And then also at an institutional level, being able to grow these areas and even just having an ECMO program with good outcomes is something that they can use to advertise and enhance their reputation. How do we quantify the value of ECMO from a scientific point of view? There's this thing called the incremental cost effectiveness ratio. And this is the thing that almost everyone will compare when a new therapy comes out. They compare it to whatever the reference therapy is, whether it's control or just the older therapy. And using that, you compare the cost between the old and the new, ECMO versus, say, just mechanical ventilation, and then quality of adjusted life years that were gained with the new therapy versus the reference, say, ECMO versus just mechanical ventilation. And with that, you come out with a number that says how many dollars it takes to gain each incremental quality adjusted life year. And the Institute of Clinical Economic Review, which coincidentally also has the acronym of ICER, suggested that this threshold should be up to 100 to 150,000 per quality adjusted life year. This is the same that American College of Cardiology and American Heart Association came up with as well. And WHO also put it in more of a global term as 1 to 3 times per capita GDP. And in the US, this works out to roughly the same as what ACC and AHA said. So that says that if any therapy costs less than that per quality adjusted life year gained, then it is justifiable and should be supported. So what do we know about ECMO therapy and how it stacks up against other common therapies out there in the medical world? For ARDS and the use of ECMO for ARDS, the ICER is just 28,000 per quality adjusted life year, which is not too bad. ECPR has a wide range, anywhere from 17,000 to 86,000. And this wide range mostly comes down to selection criteria. So if you use the perfect selection criteria with the highest odds of success, you'll end up with a much lower ICER. So if just shockable rhythms, very low, short ischemic times, then your ICER is much better. This is sort of a great example of why selection in ECMO is so essential. Neonatal ECMO, like a meconium aspiration, also has a great ICER well below the usual thresholds. TAVI versus a standard AVR was found to have 55,000 for quality adjusted life year. Intermittent hemodialysis for end-stage renal disease. This is sort of the pillar that was originally set in the US by Medicare as the maximum justifiable amount per quality adjusted life year. And that was at 85,000. CML for chemo, about 50,000. Flu vaccinations for all healthcare workers, about 35,000. Crazy stuff like proton beam for ocular melanoma is over 100,000. Proton beam therapy for prostate cancer, about 30,000. Hypothermia, post-cardiac arrest, not ECMO related, is almost 50,000. Prone positioning for ARDS, again, not ECMO related, but that alone was about 44,000. Telemetry for low risk chest pain, all the way up close to 70,000. And then I think the most striking example here is a total knee arthroplasty, something that thousands and thousands of people undergo every year. And I don't recall anyone ever questioning, like, is it really worth spending the money on this or not? And that actually falls right in line with ECMO for ARDS. Other helpful references for you all when considering growing a program. These are nice international position papers, one for respiratory failure in adults, and then another more recent one for cardiac failure in adults. Nice broad list of authors, including some pretty notable Canadians in there. And then ELSO as well has just a host of great resources there. Another thing to look into would be ELSO and its Center of Excellence program. It's not just to make you look good or win an award, but I think the actual process of going through it and critically evaluating what you're doing and how your outcomes are can really help a program grow and develop over time. Once you do get an award, it helps with marketing for the hospital and potentially helps motivate people to keep improving. I think in summary, hopefully what I've emphasized to you all is the value of sort of intentional ECMO program growth, focusing on areas of most importance and highest importance for your hospital, and then taking chunks as you expand, hopefully getting some good early wins to build upon. And then number two, hopefully I've said it enough and I'll keep saying it again, patient selection is absolutely paramount. And I'll open it up to any other questions.
Thank you so much, Dr. Bowman. That was very salient. It's great to see all that laid out in a very deliberate way, just to sort of show what it takes to get from A to Z. I think we'll line up some other people for questions, but one other thing that springs to mind, I was just curious how that evolution was affected by or occurred during the enormous spike in need for ARDS during the COVID pandemic for you guys. Because a lot of this is sort of, anticipatory and deliberate, but I would imagine during an enormous emergent increase in need, a lot of that had to kind of happen in an ad hoc basis on the way as you went. So I'm just curious what that experience was like locally for you guys.
Yeah, absolutely. Biggest challenges for that were just coming up with enough staff to cover the increased volume of patients. On the critical care end of things, we stood up another service line that was skilled enough to help in other just general cardiac surgical patients, so that those of us who already had ECMO training or at least some ECMO exposure could just move into those positions where we would be responsible for the ECMO patients. With that volume of ECMO patients around, the most important thing was that we had one person at all times who was ECMO savvy and experienced in the unit at all times, so that whether it's troubleshooting, a colleague watching an ECMO patient needed some help, or there's a new consult that needs to be cannulated, there was always one of us in-house at all times. I'd say most of what we set up was not sustainable for more than the 2 years that we had to do it. There was a lot of text chains and calls around to colleagues and occasional people coming in who were not on service but would come in and help cannulate, those sorts of things, just to help plug the gaps and help out here and there. And then as far as bedside staffing goes, we just had to, at times when we were at capacity, had to sacrifice some of the polish that we use in for our ECMO patients. And by that I mean, most notably, we would keep them more sedated than we'd like to, and forego physical therapy and mobilization on some days, which isn't perfect, but that I think still was beneficial for our patients to be supported on lung rest at the time, even without PT for a day here and there.
That's great. Dr. Nagpal, who's for context, our own local medical director of our program and cardiac surgeon and intensivist.
Wonderful.
Yes, it's a great talk. Really, it's so nice to have a very honest and open review of the reality of growing a program. Yeah. Probably, as John has probably spoken with you on multiple occasions, in London, we've got a program that we've always wanted to grow. And so we've started much smaller in the 90s, but have slowly grown with our volumes over the past years. And we've been fortunate recently to formalize it. And now we have bedside nurses who are primarily responsible, thanks to really our perfusionists who have trained them up and our critical care nurses who have taken it on. I'm wondering well, there's so many questions that we can kind of bring up and talk here, but really I have 3, and I'll just ask one and then I'll take my turn coming next. But one thing that's come up is what you think in a Canadian system would be an appropriate way to grow. I mean, have you worked with other Canadian programs where funding for not only the technology, but particularly the human resource aspect is most challenging? I'm sure you, like us, are having trouble retaining critical care nurses. Yeah. And your last comment about us needing to keep our ECMO patients more sedated than we'd like to is really something that we struggle with. If we had more physio, if we had more critical care nurses, or if we had more perfusionists to train maybe ECMO techs, all of these things I think would really help. I'm wondering what you see as a strategy for a Canadian program such as ours to really move forward with program growth, but more importantly, with improving the quality of care around ECMO patients that we really see.
Yeah, thanks for that. I guess my main exposure to the Canadian system was back when I was training, I spent some time with Eddie Fan over in Toronto. So as far as the nitty gritty about actually getting funding and actually being able to hire up to that in the Canadian system, I don't know that I have a great specific Canadian answer for you, but am certainly more than willing to make a contact between you and Eddie if one hasn't already been made. He's a fantastic and knowledgeable guy.
Yeah, I mean, the advantage of Canadians is that we all know each other.
Yeah.
Kind of tongue in cheek. So we work pretty closely with Eddie and the Hamilton program and across Canada as well. And I guess really what I'm thinking, based on your experience and your program growth trajectory, did you find specific areas where you were able to become more cost effective? The whole ICER example slide that you give, that was excellent, by the way. But were you able to create a business case for definitively showing administration, and for us it would be at the provincial level, why having more ECMO specialists would actually help patient outcomes? I think we need some hard data in Canada so that we can really drill down on a business case.
Yeah, I haven't seen great objective data to prove the business case for ECMO specialists. Just for program growth in general, yes, we made a business case for staffing up, taking over more ICU beds to recruit more patients from the region, and a lot of that was helped by just the positive margin of ECMO programs in general. And I think that here at least was the overall impact was enough justification for us to build up all of the other resources around the program that were required, including ECMO specialists along the way. But fortunately for us, I didn't have to make a specific case for the ECMO specialists staffing ratios. We may run into that soon though. We were just chatting before the talk here about how short we are here, and really everywhere I've talked, everyone's just short staffed, and there's some sort of mismatch between acuity and experience as well. We've lost so many senior experienced nurses that I think that might be an exaggeration, but it's a bit like it's irreplaceable. You can't just pop a brand new nurse in and expect them to do nearly as much as an experienced 20-year nurse can. But that's what we are being expected to do. I'm hopeful that with some time, this wave of resignations will pass and it'll stabilize a bit, but maybe that's just some naivete on my part.
I think, John Basmagic, I saw your hand up, unless you decided that your question was answered, perhaps. We can move on to Alex with your question next.
Yes, hi. Thank you so much. I really enjoyed the talk. I was just going to ask about your thoughts on embedding research into growing programs, and what your ideas would be to start, for good questions to ask in the context of observational studies related to improving patient care and contributing to the worldwide knowledge around ECMO complications and benefits.
Yeah, thanks. I think there is loads and loads of data that we could get prospectively. I mean, there are just gobs and gobs of retrospective observational studies out there now, but we're really missing in the ECMO world are prospective things, just because of the accuracy involved and so many of those details that are lost that you can't really capture retrospectively. I think big areas of need are, one that we just touched on is physical therapy, immobilization, and the true clinical impact on outcomes of those interventions. Some of other things, anticoagulation still a big question out there, and plenty of patient selection questions are out there as well. I think if you have the ability to have either research fellows or coordinators there that can help develop and populate a registry for you, I think that would give you a really unique set of data. Either that or join one of the research networks that are already well established that you could join in on some of the trials that they have running, like ECMONet, for example. It's just the power in numbers. I think one of the big challenges for ECMO research is any individual center hardly has enough, even a big center hardly has enough patients to have enough statistical power to really get good answers. So it needs to be done in groups.
Oh, I think you're muted, Alex.
Sorry about that. No, thank you so much about, the, really expert opinion about the prospective nature and the lack of that data and the value of registries. That kind of confirms what some of us have been chatting about here. Thank you very much for sharing that.
Yeah.
Dr. Mankewell, go ahead.
Yeah, kind of John, you've already alluded to this with your question regarding change management and program development, but I'm wondering about your experience when you really took on the reins of the program. A few years back when we formalized our program with a local guideline document, we decided to take an all-inclusive approach, predominantly cardiac surgery and perfusion, of course, because those were the parties that were most kind of, I guess, involved. But really, we asked every single person, every player, obviously intensivists, critical care nursing, administrators, we asked everybody to come to the table to try to formalize our guideline document. The advantage of that, of course, is that it facilitates sort of cultural change, and that really was what we needed to, excite our nurses to look after stable ECMOs at the bedside. But inevitably, when you have a lot of people together, there will be differing opinion. So I'm wondering how you manage that. It could be very large, kind of strategic decisions versus very small, for example, parameters on a ventilator or PTT targets or whatever. Did you decide, I'm curious about how you decided to take that on. There's obviously a few different strategies.
Yeah. I admire you for polling the big, broad group. And that is very challenging to come to a clear consensus or a very defined consensus. So what we usually do is there's a group of probably 10 of us that are the most interested in ECMO amongst the intensivists here. And we'll do a lot of the initial work amongst that group for guideline formation. But there are certainly some topics that, well, first of all, as much data-driven guideline formation as possible, because there are plenty of issues still that are just very gray. There's not a lot of black and white in many areas of ECMO. So whenever possible, if you can get as close to black and white as you can. An example of a recent and really still ongoing discussion amongst our group is what to do with sedation management and ventilator parameters for COVID ECMO. The traditional respiratory failure on ECMO may have an ECMO run of, say, 7 to 14 days. And if you are needing to sedate them to achieve true lung protective ventilation for 7 to 10 days, then that's fine. You can probably justify that. But these COVID ECMO people are maybe on ECMO for 30, 40, 50 days. And the thought of sedating someone deeply for 30, 40, 50 days just to achieve true lung protective ventilation, it, in my mind, becomes more challenging to justify, especially because there's obviously no trial to prove that either. So then there becomes a huge discrepancy in opinions about, hey, we need to be really strict about lung protective ventilation because obviously they have ARDS. And then the other camp saying their lungs are injured anyways. Maybe I don't even believe in patient self-induced lung injury, so we can extubate them and they can huff and puff all they want. I don't care. I need them awake and I need them doing PT, because if they're not awake for 40 days, they're just going to be debilitated. And what's the point then? So those sorts of dichotomies in opinion, I think are somewhat inevitable when we push the envelope. But with guidelines, what I've tried to do is capture, say, 90% of the usual clinical situations and get probably 90% of the clinicians to buy in on that, understanding that it may not capture all the patients. There'll be some exceptions, and it may not capture all of the clinicians involved. There may be some exceptions. And I think that's just part of being in an opinionated, smart, innovative, collegial environment where there are going to be some opinions that you don't necessarily agree with, but you have to tolerate. The tougher conversations are trying to take those who fall off the normal distribution curve, you know, the ones who say don't believe in patient self-induced lung injury and don't care if the patient's puffing and puffing for 30 days, and trying to get them to come back closer to what the consensus is. Methods that I found helpful for gathering people closer to the consensus are reminding them of the fact that our service hands off over time. So a patient and their family may have one provider team for 1 week who take on a certain approach. The last thing we want is someone new coming on service, a new intensivist for the next week, and totally changing everything and saying, you know, whether directly or indirectly saying, what the people did last week was totally wrong because we're going to totally switch it. I think if they realize the perspective of the patient and the family, they may be more likely to stick with the strategy used by the team the week before. And that may be something that will eliminate some of this oscillating between service teams handing off with different opinions. It's kind of a long answer on a very specific example, but it illustrates you're certainly not alone. And Ecmo, I think amongst many things, because of all the gray areas and lack of really definitive data, is prone to that sort of thing.
Paul, did you have a question? I know you had your hand up.
That's okay. I'm done. I think we're kind of coming up to time, so I'm happy to just save it for another interaction.
Great. I'd like to thank you once again, Dr. Bowman, for joining us. It was an excellent talk, and that's exactly the sort of overview I was hoping to share with people, just about, you know, a center of excellence in your approach to evolving things. You know, a lot of it seems like common sense, but it's great to see everything explicitly outlined like that, and to know that, you know, even the Mayo Clinic can learn things and grow and develop. So it's so great to have you with us to speak. So thanks so much for joining us.
Great to see you, and really a pleasure to be here and to meet you guys. And don't hesitate to email questions or whatnot. I'm happy to take them and either me give you an answer or find someone who can get you the right answer too.
I'm sure I will be in touch in the future. All right. Thank you very much. And thanks everyone for joining us.
Thank you so much.